joining us today for our webinar session on Physician Quality Reporting System, or PQRS, reporting with MeHI's Registry and Services. My name is Liz Renchkowski, and I'll be facilitating today's webinar session. Today I'm joined by my colleagues Al Robleski and Jillian Landry. Al is a Client Services Relationship Manager here at MeHI, and Jillian Landry is our PQRS Advisor, and we're happy to have them to walk us through the content today. We're going to begin with just a quick disclaimer. This presentation was current at the time it was presented, published, or uploaded onto the web, and the presentation was prepared as a service to the public and not intended to grant rights or impose obligations. So essentially this is saying that the presentation is informational in nature, and it's intended to be a general summary of the content. It's not intended to take the place of either written laws or regulations. So we do encourage all attendees to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Just to go over the agenda for today, we'll start with a little bit about who we are here at MeHI. We'll talk about PQRS context and the rationale for why PQRS exists. We'll talk a little bit about your practice and PQRS eligibility, the reporting methods and reporting considerations, MeHI's qualified registry, the future of PQRS and quality reporting, next steps. At this time, I'm going to turn it over to my colleague Al Robleski to talk a little bit about MeHI and who we are. Al?
Thank you, Liz. So we're the Massachusetts eHealth Institute, and we're part of Massachusetts Technology Collaborative, a public economic development agency, part of the Commonwealth. Our mission in life is to really promote the widespread adoption and use of electronic health records across the Commonwealth in all healthcare settings. So we have a very ambitious goal and mission, and we're very committed to facilitating everyone's success in using health information technology to leverage the quality of care, reduce prices, and of course, a dimension that I'll just touch on briefly is patient engagement, which is the expansion of the shared responsibility for our health out of the profession-driven medical system into where each of us takes on more responsibility for our own health. So technology can be a tremendous asset in moving healthcare in a direction where it's a shared responsibility between the providers and the patients themselves. So MeHI came about in 2008. Legislation called Chapter 305 created us rather unique among states that we have an entity that is not a direct line service agency like Mass Health, but we're here to facilitate and promote the use of health information technology. In 2012, Chapter 224 was passed, and this expanded our responsibilities and also gave great emphasis to working with practices beyond primary care. So that means behavioral health, long-term care, dentists, chiropractors, virtually everybody who's doing healthcare of one sort or another, because the real benefit of it is if it's all connected and there's communication and two-way data exchange, the quality of care and the avoidance of errors or mistakes, problems with prescribing and so forth can be reduced dramatically. In the bottom section there, we're here to help, and I love that term, navigating. That's what we're here to help people do, how to navigate through the regulations, through all the different interpretations of rules, requirements, and help you keep moving down the path of providing excellent clinical care. In that light, we've chosen to expand our menu of services. We initially began with facilitating the introduction of the Mass Highway, the review of applications for the Medicaid Incentive Payment Program, and the Regional Extension Center, which provided assistance in practices moving from paper to the computer and then achieving meaningful use. Now we have rolled out a new menu of services we call the eHealth Services and Support, and I just want to touch on this very briefly. The first section there where you see providing help with meaningful use gap analysis, where we take a look at where do you stand in terms of meeting the measures, where are the difficulties, and what are the strategies that can help you move forward. Part of what we've learned in reviewing the applications for the Medicaid Incentive Payment Program is the more work that can be done ahead of time in terms of planning and really making sure that you're meeting all the measures and that you're creating the proper documentation speeds up the review process significantly. And that leads to the second point, registration and attestation. For those of you who have been personally involved in that, you know that sometimes that can be somewhat problematic in figuring out how do you get everybody registered and aligned with the information at the mass health level. So again, we will provide additional assistance. One of the challenges we face with those analysts who are going over the applications is to provide another level of support beyond that so they can stay focused on processing the applications as quickly as possible. Third bullet point, secure document storage and audit preparation. May sound rather innocuous, but it actually is very, very critical, as supporting documentation is required for submitting your application to Medicaid. It's important to make sure that is done contemporaneously. In other words, as you're within your meaningful use reporting period, you are capturing screenshots, reports that are being generated from the EHR to really document that you are in fact meeting the measures and meeting all the requirements. So this is a mechanism of basically a repository for that documentation. Audit prep is also very important because the supporting documentation is necessary should you be audited, and this is a way of facilitating you collecting the right information and storing it properly. Essentially, this whole page is really talking about a member portal, which is the tool which organizes all of these various services. And it's important to particularly very small practices where organizing this information in one spot can be tremendously useful if there's a change in personnel or somebody is on leave and somebody else has to step in. So we've really seen that as just a tremendous asset in supporting infrastructure. The next one is the qualified registry for submitting PQRS, which is what we'll devote the remainder of the webinar and talking about that. We have a couple of external partners, patient engagement resources, and the privacy and security tools. Privacy and security, what this provides is actually allows you to do the risk analysis, which meets the meaningful use measure. This has been a very difficult area in terms of Medicare providers. Many of them have been, well, not many, but a good number of them have been asked to give their payments back because their security risk analysis were found to be deficient. So this blueprint security risk analysis has proven to be effective and has met the requirements if filled out properly for meaningful use. So that's a service that is now available through MeHI and the member portal. And at the bottom, we want to continue reaching out as a public service to providing informational webinars like this one, training courses, and really helping the healthcare community of Commonwealth to really see the opportunities that exist in exchanging data, working together, and continuing to learn from one another. So this menu of services, we call it the membership portal. There is a fee involved with that, and we'll discuss that a little bit at the end. But we encourage you, if you have questions about the eHealth services, please reach out to us and we'd be happy to answer any questions. Okay, let's take a look at PQRS. So the purpose of PQRS, if you look at it on a global level, is beginning to look at how do we compensate providers for keeping people out of the emergency department, rather than the current system, fee-for-service, which is driven by transactions. The more transactions, the more expensive the transaction, the more money. And this is, in a way, at odds with trying to reduce health care costs and putting an emphasis on prevention. So the Centers for Medicare and Medicaid Services, they've come up with a number of different approaches. In some ways, they're all similar, and it can be frustrating for the providers to keep them all straight, but they're all intended to move in the same direction. These are things like the e-prescribing incentive program, the HR incentive programs, value-based payment modifier program, shared savings, advanced payment ACO model, pioneer ACO model. So all of these are looking at ways of capturing success in preventing high-cost procedures and in ways of preventing mistakes, duplication, having to do tests multiple times because you're not aware that the test was just done by another provider because you don't have access to that information. So that's the basis of PQRS, and as I mentioned, it's one of several. And it is an interesting program in that it provides incentives, in other words, additional payments, but also negative adjustments so you have incentive and disincentives. So PQRS is a tool which is contributing to this movement away from fee-for-service. How does PQRS work? Eligible professionals report on quality measures for covered physician fee schedule services. So it's basically for Medicare Part B fee-for-service beneficiaries. Now, eligible professionals is a term used for the incentive payment programs, and it means specific things in terms of who is eligible for that. In terms of PQRS, eligible professionals means not only those profession types, but an array of additional clinician types. So it can be a source of confusion, but Jillian will explain that further on in terms of the additional professions who are considered EPs for the purpose of PQRS. And if you are participating in the Medicare Accountable Care Organizations, that essentially covers it because you're reporting through the ACO, and you do not need to also report through PQRS.
Okay, we're going to pause here and do a quick knowledge check. One of the questions that we have received from the provider community is the following. I work for 2 different organizations, so I have 2 different NPI TINs I bill under. Which one do I use for reporting? The answer is eligible professionals must report for each NPI TIN combination they use to bill Medicare during the 2014 calendar year in order to avoid the 2016 PQRS payment adjustment. So this is extremely important, and we want to stress this piece of information so that people are aware that if you do have multiple NPI TIN combinations that you bill Medicare under, it's important to report PQRS measures for all of those NPI TIN combinations in order to avoid the payment adjustment. Jillian? Thank you. Thanks, everyone, for being here today. Again, my name is Jillian Landry, and I'm a PQRS advisor here at MeHI. And I'll talk a little bit more about the context and what it means for you and your practice. So what are these PQRS incentives and payment adjustments? Well, for the 2014 program year, which is what we're going to be reporting on until March of 2015, the incentive is 0.5%. So that 0.5%, if you're successful in reporting, will be issued as a separate single consolidated payment in 2015, most likely in the fall of 2015. On the other hand, the payment penalty is a negative 2%. And the way that the program is set up is that these adjustments occur in a 2-year gap. So your reporting for 2014 will apply to your Medicare reimbursements in 2016. It is important to note that the 2014 program year is the last year to earn this automatic incentive. It's been phased out by CMS. Additionally, payment penalties will continue. So failure to report in 2015 will result in a payment adjustment in 2017, and so on and so forth. It's also important to know that these penalties are in addition to meaningful use penalties and value-based modifier penalties. I'll talk about the value-based modifier program in the next slide. But again, just to reiterate what Al has described, this is a push for providers to move away from the fee-for-service model into more of a performance-based model. So why should you participate in PQRS? Well, most obviously, for 2014, you'll earn an incentive by successfully reporting and also avoid payment penalties. But it's also important because of this value-based modifier program. And this program for 2014 currently applies to group practices with 10 or more eligible professionals who are practicing under the same tax identifier. And this value modifier program has been phased in. So for instance, in 2013, it affected groups of 100 or more. So going forward, this is going to apply to all practices, including solo practitioners. And what this means is that it could result in additional penalties of up to negative 2%. So an example here at the bottom shows here is a group of 10 or more eligible professionals. They bill $2 million to Medicare. If they're successful in reporting, they avoid penalties and earn $10,000.
However, if they're not successful or they refuse to report in PQRS, there's the PQRS penalty that -2 will amount to $40,000. And then there's also the value-based modifier penalty of another -2% or another $40,000. So this -$80,000 penalty, as you can see, it adds up quickly. To kind of show you PQRS and value-based modifier in a chart format, here it is. So on the left-hand side with PQRS, you can see physicians, practitioners, and therapists by not reporting will receive a -2%. Of course, if they do, you'll get that 0.5% incentive. Now, the value modifier applies only to physicians in groups. However, the way that you determine a group size is by adding everyone in the group, including not only physicians, but practitioners and therapists. So by not reporting, if you're in a group of 100 or more, it's a -2. Depending on the quality of your reporting, there actually would be a downward, neutral, or upward adjustment. These -2 or -1, +1, +2, and there's an X here because that dollar amount isn't determined. So based on the 2014 reporting and the quality, CMS uses this tiering approach to determine the quality of your reporting compared to your peers. And so essentially it's a redistribution. Those who are underperforming, those penalties will be redistributed as a upward adjustment or neutral to those who are average or overperforming. If you're in a group from 10 to 99, again, by not reporting, it's a -2. By reporting, right now, there's no negative adjustment. There's a neutral or plus. Again, just to stress the value modifier program, the only way to avoid these penalties, although value modifier is considered a separate program, but the only way to gain the extra incentives or avoid those penalties is by participating in PQRS.
Just going to pause and do another quick knowledge check. One of the questions that have come in is, what is the payment adjustment specifically for the value-based modifier? The answer is kind of lengthy, but we'll work through it. The value-based modifier payment adjustments are based on quality tiering, as Jillian mentioned. Quality tiering is the analysis used to determine the type of adjustment, either upward, downward, or neutral, and the range of the adjustment based on the performance on quality and cost measures. Quality tiering will determine if a group's practice performance is statistically better than, the same as, or worse than the national mean. The exact amount of the adjustment cannot be determined until the data is analyzed and the quality tiering is complete. For more information on the value-based modifier, you can visit the CMS site. They do have a pretty good overview there. But the big takeaway here is that the exact dollar amount of the value-based modifier can't be determined until CMS has done their analysis and determined how they're going to redistribute the money and basically, take away from those who are underperforming on the measures and redistribute that to the folks who have performed well on the measures.
Okay, thank you, Liz. So what are the steps for your practice? So the first thing that you'd want to do is first determine your eligibility. Secondly, choose a reporting method, and we'll go over the different methods that are available to you, including MeHI's registry. The next thing would be choosing measures to report on, followed by the collection and organization of data, and then finally the submission of that data. So this is the sort of roster of PQRS eligibility. As Al mentioned earlier, you can see how the EHR incentive program eligible professional definition does not include practitioners or therapists. So we've talked to people who have said, oh, well, I don't qualify because I don't participate in the EHR incentives. But we are quick to try and educate the provider community that most likely you are. And so by not reporting or thinking that you're not eligible, you would be subject to a payment adjustment. So again, just the different types of clinicians that are eligible for PQRS.
Another knowledge check here. The question is there a minimum number of Medicare patients I need to see to qualify for PQRS? And the answer is eligible professionals who had at least one eligible Medicare Part B fee-for-service patient encounter during calendar year 2014 qualify for a PQRS incentive payment and will be subject to a -2% payment adjustment in 2016 for failure to report. So the big message here is that if you saw at least one Medicare Part B fee-for-service patient during 2014, you are considered a Medicare eligible professional for the purposes of PQRS. and you would be subject to that payment adjustment in 2016 and also potentially qualify for a 2014 PQRS incentive payment if you report your measures successfully.
Okay, thank you, Liz. So we'll talk here about the reporting methods. One thing that we want to point out is that there is still time to participate for 2014 PQRS through the following reporting methods. One would be qualified registry, which MeHI has. Secondly, you could do a qualified clinical data registry, or QCDR. Thirdly, there's direct EHR using your certified EHR technology, or there's cert via data submission vendor. There is also another way to participate, and that is called claims-based reporting. This would have had to have been set up with your billing for the 1st of 2014, January 1st, 2014. And so if that hasn't been something that you've been doing all along, then it would be too late to use this method. In terms of deadlines for PQRS data submission, if using direct EHR or CERT, that is February 28th, 2015, which is coming up shortly. MeHI's qualified registry, our deadline is March 19th of 2015, and the QCDR deadline is March 31st of 2015. Another thing that PQRS allows you to do is participate using the group practice reporting option. And a group is defined of 2 or more individual EPs where they have reassigned their billing rights to the group. And what this does is it allows you to report on the group's total Medicare patient population instead of reporting individually for each eligible professional. There are 2 additional ways to report from the slide before. So, of course, you can report doing the qualified registry, direct EHR, or CERT. There's also web interface. This applies to groups of 25 or more. And there's also the Clinician and Group Consumer Assessment of Healthcare Providers and Systems, or CGCAP. This is through a CMS-certified survey vendor, and again applies only to groups of 25 or more. In order to take advantage of the group practice reporting option, or GPRO, you would have had to register your group's intent to participate in PQRS by October 3rd of 2014. So if that's not something that you were able to do for this year, that's okay. You can participate as individuals. However, moving forward, if it ends up being a strategy for you with your reporting, the deadline is June 30th to submit your intent. And that actually opens April 1st, so not too far down the road here, and the registration must be through CMS, through their physician value PQRS registration system. So once you decide how you're going to report, you're going to want to figure out if you're going to use individual measures or measures groups. Individual measures, these are sort of the parameters. You must report on at least 50% of all eligible encounters for the measure that you've selected. All of the measures must have a greater than 0% performance rate, or in other words, performed for at least 1 patient. Reporting 3 measures, you're eligible to avoid the 2016 payment adjustment of -2%. However, by reporting 3 measures across 3 national quality strategy domains, you're eligible for the 2014 incentive and also avoiding the payment adjustment. It is important to note that if you register your intent to participate through GPRO, individual measures will be the way that you report PQRS. Alternatively, we do have with MeHI's registry the opportunity for eligible professionals to report on measures groups. And what these measures groups are is a group of related measures. So for instance, diabetes or HIV/AIDS, there's 25 of them, and MeHI has access to all 25 to report on. Once you choose the measures group that you want to report on, the eligible professional would choose 20 eligible patients, majority of which must be Medicare Part B, so you have an opportunity to mix in some non-Medicare beneficiaries. And again, just as the same as individual measures, you must have a greater than 0 performance rate, which if you've participated with Meaningful Use through the EHR incentive program, you don't necessarily have to have a greater than 0 performance rate, so it is important to know. We do have over 200 individual measures to choose from, and again, 25 measures groups.
Okay, another knowledge check here. I have a low Medicare volume, so I don't have 20 patients or 11 Medicare patients for any measures group. Can I report on less than 20 patients and at least avoid the payment adjustment? So the answer for that is, for 2014, eligible professionals reporting a measures group must report all applicable measures for 20 eligible patients. And as Jillian mentioned, at least half of those, so 11 or more, must be Medicare fee-for-service patients in order to avoid the 2016 PQRS payment adjustment. If an eligible professional does not have enough patients to achieve this with a certain measures group, the EP can choose another measures group that can be reported for 20 patients or 11 plus Medicare fee-for-service. Otherwise, the eligible professional will need to report individual measures using all of their 2014 Medicare patients.
Okay, so another consideration when it comes to choosing measures is this Measures Applicability Validation Program, or MAV program. And this is new for 2014 that CMS came out with. And basically, if as an eligible professional you report less than 9 measures or 9 or more measures covering less than 3 domains, the MAV process will be applied. And what it does is it determines whether or not an eligible professional would still be eligible for an incentive despite reporting less than those 9 measures or 9 or more measures covering less than those 3 domains. So in order to actually receive an incentive through this MAV process, the EP or group must either satisfactorily report all applicable measures within a clinical cluster. This is different from measures groups, but it's a MAV clinical cluster, or satisfactorily report on measures not included within one of these MAV clinical clusters, while also passing the CMS clinical relation domain test based on the measures within the clinical cluster. So this process is strategic. It helps a lot of providers who may not traditionally be able to find 9 measures that relate to their scope of practice, especially behavioral health, for instance. It's a way that, by signing on with us at MeHI, we would determine if this would be more advantageous for you, less data collection and more strategic, so that you would be able to perhaps still receive that incentive and avoid the penalty if the individual measures and measures groups methods do not work for you. In terms of reporting considerations, the factors that should be considered when selecting measures: first, clinical conditions that are usually treated, types of care that are provided and where that care is being provided, settings where that care is usually delivered, if it's in an office or emergency department, any quality improvement goals for the practice, or other quality reporting programs in use or being considered. And at this time, I'll go ahead and pass it back over to Al, who will talk more about MeHI's qualified registry.
Okay, thank you, Julian. So one of the nice features of the qualified registry is the assistance you get in terms of navigating your way into submitting the quality measures. And that we found to be more and more valuable as the complexity of various programs like PQRS continues to grow. And it's very difficult just to have the bandwidth within your staff to stay on top of everything. So part of it is, yes, this is a way to report, but it also is a way to get additional support to facilitate your success, not only in reporting, but in making some of these decisions as to which measures to use, and making sure that your EHR or other software is capturing the data you need accurately and correctly, so that you have basically the soup to nuts covered in terms of being successful at submitting these measures. One of the interesting things that distinguishes PQRS from the meaningful use clinical quality measures is, for meaningful use or the incentive payments, there is no particular threshold. You don't have to hit a certain percentage. With PQRS, where you're actually moving into a sense of success, so to speak, a success measurement or performance measurement, part of it is not only in terms of capturing the data, which is what's required for the incentive payments, but actually being successful in terms of training your clinicians, workflow, and capturing successful reporting of what is being done during patient visits. So PQRS, in a way, takes it another step then beyond the clinical quality measure reporting required for meaningful use. And the last bullet point there, MeHI can help you strategize and prepare for future reporting years. So again, I want to emphasize that because it isn't simply a matter of, at the last minute, pulling together your data and submitting it. It really is about thinking strategically as you're moving through the year, like even now, as Jill pointed out, to register your intent to go with the G Pro option. The window for that opens in April and closes in June. So part of it is not only do you want to be successful in submitting measures to CMS, but you also want to look at this as how do you make this clinically useful within your practice. And that, unfortunately, is often missed because people, simply feel the pressure of having to report. But the whole point of this is to improve clinical outcomes. So PQRS is with us for the foreseeable future. Potentially it'll change names or morph into something else, but the whole idea of capturing data and using it as a description of success in performance is definitely the direction healthcare is moving. So part of it is getting comfortable with it and looking at it not only as a compliance issue, but as an empowerment tool to help your clinicians produce better outcomes for your patients. So that's an important aspect that I emphasize a lot, which sometimes gets lost when you feel like you're just under the gun to meet these various requirements. The second bullet point there, well, I'll go through the first 4 items there, just that it will become more stringent. Hopefully, these will become better aligned with other programs. I think that's been very maddening for many people that there are all these different programs with different requirements around quality measures. And I think CMS has heard that complaint and is attempting to align these and consolidate them, pull them together, so you have to report in 14 different ways. Going from the individual to the practice level, this is very much a trend that any of you are involved in the patient-centered medical home. That's a dimension of this, where really it's looking at how is the practice performing as a whole, because more and more the individuals are really conforming to the protocols and workflows that are established in the practice, and they're not independent operators just choosing measures on their own. Last point is in terms of the incentives and penalties, and again that idea of tiering, which is essentially at this point anyway 3 tiers. Are you underperforming, performing in a neutral way, or excelling in performance? And then there is a redistributive function which then rewards success and penalizes people who are not meeting the measures adequately. As I mentioned, quality reporting, PQRS, definitely here to stay. The dollar amount, incentives, payments will continue to increasing, and the reimbursements are going to be tied to performance. That graphic is basically informing you that more and more of this information will become available to the public. So consumers will have the opportunity to look at quality performance as at least one metric to consider making their choices as to where they're going to seek care. One other thing I guess I would say about this is which quality measures you choose will in a way become more and more significant in terms of your practice. For example, with meaningful use in incentive payment programs, there are requirements in stage 2 where you use clinical quality measures as a tool for setting your decision support rules. I encourage people to think of this sort of in 2 ways. One, yes, you have to meet the requirements, but 2, are you finding clinical quality measures that are particularly relevant to your practice? Are you focusing on them and using them to assist you in providing better patient care? So if you're interested in following up with us and utilizing the registry, you can give us a call at 1-855-MASS-EHR, send us an email, or visit us on the website. Remember, to submit PQRS through our registry, we have to have the information before March 19th of 2015.